transition in the interest of time over to Angela Roberts, who's the 988 Program Administrator with the Division of Mental Health Promotion, Prevention and Preparedness at the BHDID. And Angela is going to be here to talk with us about how to leverage the new 988 capabilities with your patients. Angela, thank you so much for being with us.
Well, thank you so much for allowing me to come and talk. So as she said, my name is Angela Roberts. I've been in the position of 988 Program Administrator for a year, and I've had the pleasure, privilege of working with all of our community mental health centers, including Darcy and her team at New Vista. So next slide, please. So 988 is nothing really new. The concept of it is not new. And I'm sure everyone is familiar with the National Suicide Prevention Lifeline of the 1-800-273-TALK. That began in 2004, and over time, it has actually evolved to where it is now of more than 200 crisis centers across the U.S. And the thing about it is that it is a 24-hour, 7-day-a-week, confidential and free service available to anyone in crisis. Now, I said that the concept of 988 is not new. What is new is the way that 988 is being presented. So when we were preparing for this, we were working on, as a state, to have all of our community mental health centers that already had crisis lines for their local areas become part of the NSPL network, or the National Suicide Prevention Lifeline, and then make that transition over to 988. So the work has begun several years ago, around 2018 when this started. So next slide. So this is how Kentucky is structured. We do have 14 community mental health centers, but of those, we have 12 primary centers that cover all 120 counties. So the ones that are shaded green are the ones that for which we have 988 centers located within the community mental health centers. The ones that are green and white striped are centers that have coordinated with another center to take on their calls. So again, all 120 counties are covered. Next slide. Where we're working to build capacity is that we're at about 88% coverage for backup of all of our counties. So pretty much everything in blue is covered by a backup center in Western Kentucky, which is Pennyroyal. And we're continuing to build capacity for the other 6 counties outside of Pennyroyal's area by working with our community mental health centers to build that, so that we can ensure that, as Darcy was saying, that the calls are routed by area code and prefix, that they stay in Kentucky. And our goal is to ultimately get to 90% answer rate with that. So we're continuing to build this capacity as we're now 7 months post launch of 988. So continuing to do the work. Next slide. So as I said, 988 is not a new idea, but the concept of it is, and it really started in 2008. And these are just the different laws and the acts and laws that were enacted to get us to where we are now. What 988 really is a change in the crisis continuum. Where it was before the National Suicide Prevention Lifeline, for those experiencing a suicidal ideation, it has evolved to where it is now, where it's the 988 Crisis and Suicide Lifeline. So it's expanded out. It's gone from becoming a line for someone, first person experiencing suicidal ideation, to someone who's having a mental health crisis, whether they're experiencing anxiety or depression, or there's some other issue that they may have. But it's also expanded out so that it can be a third person calling. So we have evolved to that. And this is just the first step of it. 988 is not our ending point. It is the launching pad for where we're wanting to go with the continuum of care. So next slide, please. So we're continuing to evolve with this. And as we said, 988 is part of a 3-phase approach to this. And the ultimate goal across the country is that we have someone to call, which we have with 988. Then we have someone to respond, and that's going to be our mobile crisis piece. And then the third piece is a safe place to go, whether that is the crisis stabilization units or an inpatient facility or any number of different avenues to meet the needs of the individual that's in crisis. So as we continue to move forward with 988 in this continuum, we're looking at our success in that. Are we able to connect individuals experiencing a crisis to the trained counselors, or for that more advanced care that they need if the calls can't be de-escalated by our crisis counselors that take the call? We want to reduce the healthcare spending by the unnecessary trips to the emergency department. And that also correlates to reduce use of law enforcement and emergency medical services, because for years it has been if someone's not familiar or knows how to access assistance for mental health, then they call 911. And that's not always the best option. If somebody is not committing a crime or they're not having a medical emergency, they're just having a mental health crisis. So we want to make sure that we have the system in place for children, youth, and our adults to be able to have these services. And that's where 988 is what we're working towards, is to continue to make it an effective system. But we also want to make sure that we're meeting the growing need for it at scale while providing accessible and equitable services. So we're identifying our high-risk populations, which you can see on here, and making sure that we're having the cultural responsiveness and we're providing the training and support to all of our centers that are taking the calls and helping them identify how to respond, as well as the resources available that's in the least restrictive environment and most efficient way of providing services. Next slide, please. So this just kind of shows you a trend of how our call volume has evolved over time. Pre-launch of 988 in July, you can see we averaged just under 2,000 calls a month. But once 988 launched, we have seen a steady increase in our call volume, which was predicted prior to going live with that. So we've been working with the centers to build capacity to make sure that Kentuckians in crisis are able to talk to someone in Kentucky who understands the cultural, the geographic, and just the general dynamic difference of Kentucky as it is. So since we went live with 988, we've been seeing about a 500 call increase each month, and we're expecting that to continue. And we haven't at this point done a huge marketing push on it because we want to make sure that we have the capacity to answer that. Because if a call is not answered at the primary center, then it will roll over to the backup center for Kentucky. And generally that's where it's answered. So we're doing that at about a 76% answer rate at the moment. But if it's not available to be answered by the primary or the backup in Kentucky, it does roll to one of the national backup centers. So there's always that the opportunity for a trained crisis counselor to assist someone and help them through that crisis. Next slide, please. Where we saw the significant increases in the chat and text once 988 went live. And you can see, particularly with the text component, when 988 launched in July, it became where you could text to 988 as opposed to a 5-digit number. So we know that the majority of those using text are our youth, and they tend to do it in the evening. So we currently have one center that is taking chat and text for Kentucky on a Monday through Friday basis for 3 hours at a time. And again, this is something we're working to build capacity so that someone in Kentucky experiencing a crisis that needs to chat or text with someone can do that with someone from Kentucky. And we're continuing to evolve that, but focusing on the primary thing and making sure that the calls are being answered, since that's where the greatest demand occurs. Next slide, please. So you've probably seen this if you've heard anything about 988, is that it is considered one of the most significant behavioral health policy efforts since the Medicaid expansion in 2014. And I say that and I reiterate that because it is something that we're working to evolve. It is not where we stop now that we have someone to answer the call. Now we're building on the other pieces that go with it. So next slide, please. So we're trying to get to the point where when you have a situation where you have a medical emergency or you need police or fire, you call 911. It's taken many, many years to get to that point from when 911 started. So we're trying to build the framework and the understanding that if you're experiencing that mental health crisis, that you can call 988 for yourself or someone that you care about. And the importance of this is, and the next slide, please, is that we want to get away from having law enforcement and EMS respond on every behavioral health crisis. And I use the example when I'm talking to law enforcement is that you have a child who has a behavioral health disorder or an emotional disorder, and they're just having a bad day and they're not wanting to go to school, but the parents are exasperated and they don't know what to do. So they call 911. Well, then that's going to traumatize the child by having law enforcement show up because it's not a law enforcement issue. So we want to get away from this unnecessary cycle of someone experiencing a behavioral health crisis, and then they're either transported to the emergency department or they are taken to jail and then released without the support that they need to make sure that they are able to effectively manage that crisis. So this is kind of the state of what we're in now, is that perpetual cycle of 911's called, law enforcement or EMS, emergency department, jail, and release with no resources or support. So if we go to the next slide, you'll see what we're trying to work towards. And that is working towards the continuum of care where we have the connection between our PSAPs and we have the information that we need to share and do those things. So we're building mobile crisis in. We're working with the centers to have the information for the community supports and resources and to build that into where there's follow-up, where there's support, and there's continued involvement with that so that we're able to mitigate the impact on our emergency services, both for law enforcement and the emergency department, while providing assistance and support in the least restrictive environment, meaning we go to where the person is at that point through mobile crisis. So next slide. So that is it in a nutshell. There are so many other things that I could actually tell you about. There's so many pieces to it between the websites and the bed registries and all the things that we're working on to support all of our Kentuckians from our youngest to our oldest. And one thing I will end on is that we're seeing a huge increase in contact from young people, 8, 10, 12-year-olds that are experiencing crises. So we know that the system is working and we're wanting to continue to do it and continue to build it to where we can support any Kentuckian experiencing a crisis. So thank you for the opportunity. And I know that was quick. I'd be happy to come back another time and talk more 988, or I'm happy to talk to anybody at any time. So thank you all.
Angela is a great resource for all of us who are interacting with patients and others who are in need. I will ask a real quick follow-up from Kathy. Angela, how does 988 differ from Smart 911 is one of the questions in the chat.
I'm thinking Smart 911 is like that next gen 911 where they know location and that. So 988 at this point, to allow for voice and choice and the anonymity, does not do any type of geolocation or geo-routing. What we are doing on the federal level, and I say we because it's the 988 piece, they're looking at geo-routing, meaning that they could pinpoint a general area for someone as opposed to a specific location. So they haven't gotten to that point yet because, again, it is about contact choice and giving them the voice to maintain that confidentiality. So there's more to come on that.
All right, good. Thank you so much.
If I can piggyback on that real quick, I think Smart 911 too is giving them its safety planning for the future. So it's like you have a loved one that has Alzheimer's or a child with some type of medical health issue, that they have that in the background. And so that's wonderful. And that's a different type of safety planning where, like Angela says, 988 is in the moment crisis and can be anonymous.
Thank you, Darcy.
Okay. Thank you so much. Well, we're going to